G'day, my name's Associate Professor Elgene Lim from St. Vincent's Hospital, and I'm here to talk to you today about hormone receptor positive breast cancer. So an overview of my talk, I'd be going through the different subtypes of breast cancer, and specifically, therefore, then focusing on hormone receptor positive breast cancer. A few slides on prevention, a few slides on preoperative endocrine therapy, and then I'd be focusing this talk on adjuvant endocrine therapy, followed by the management of metastatic or advanced breast cancer in this space. And I'll end off by talking about research initiatives at St. Vincent's Hospital. So breast cancer is not one disease, as you know. There are many molecular subtypes, and this slide here just shows a collection of over 1,000 patients, and when they're analyzed genomically, there are essentially at least 4 large subtypes. So luminal A and luminal B both express the estrogen receptor. There's the HER2 enriched subtype in pink, and then the basal-like, which is more akin to the triple negative breast cancer, in red. So the luminal A and luminal B, which express the estrogen receptor, comprise about 70% of all breast cancer, and that is the subtypes that we will be talking about today. Estrogen receptor positive breast cancer has a long natural history. This is just a curve showing the recurrence rate for estrogen receptor negative breast cancer. As you can see, the recurrence is mainly in the first 4 years, and then after that, the recurrence rate is very low. So in this group would be the triple negative and some HER2 positive breast cancers. The ER positive breast cancer, on the other hand, has a very, very long tail. So the recurrence rates are about 1 or 2% per year. Even after many, many years out, this curve goes up to 24 years. I've personally had patients who've recurred after 30 years. There is an ongoing risk of recurrence, but the recurrence rates aren't as high in the early stages. And this curve here just shows that even after 5 years of adjuvant endocrine therapy, which used to be the standard duration of therapy, even in patients with small tumors such as the T1 and 0 tumors, there's an ongoing risk of recurrence, and that risk increases over time cumulatively. Obviously, the more lymph nodes you have and the larger the tumors are, the higher the risk. So there are many different classes of endocrine therapy. Perhaps the ones that you're most familiar with would be tamoxifen and the aromatase inhibitors, anastrozole, letrozole, and exemestane. These work differently. Tamoxifen is a selective estrogen receptor modulator, so it acts directly on the estrogen receptor. And the way I explain it to patients is that it acts like a plug. It sits in the receptor, preventing the estradiol that's circulating in typically premenopausal women from binding or competing with them for the estrogen receptor. The aromatase inhibitors work differently. It works in the peripheral tissues, and it's used primarily in postmenopausal women, where the ovaries cease to be the primary source of estradiol in the system, and the primary source of estradiol is the peripheral tissue conversion of testosterone into estradiol. So that prevents that process from happening. So these are oral medications. You'll see them in the community, and they're often, I often co-manage my patients on these medications with the GPs. There are other drugs as well. So one drug here is called fulvestrant. It belongs to a class of selective estrogen receptor degraders. So as opposed to the modulators, it actually degrades the estrogen receptor. And in a way, it's a more powerful drug than tamoxifen. Fulvestrant is kind of the first generation selective estrogen receptor degrader. It's given as an injection, and sometimes, once again, also GPs help with administering this drug once a month. But we have new drugs, new SERDs coming through that are oral, very exciting. They're not standard of care at the moment during clinical trials. And then finally, there's also a way in which we can inhibit the ovarian production of estrogen in premenopausal women with a drug called Bizarrelin or Zoladex. This is also given on a monthly basis. And what this does is that it actually inhibits the pituitary stimulation of the ovarian of the ovaries to produce estrogen. So this is just a summary table of the key considerations in choosing adjuvant endocrine therapy. Tamoxifen can be given to pre- and perimenopausal women, can also be given to postmenopausal women, whereas the aromatase inhibitors can only be given to the postmenopausal women. If it's given to a premenopausal woman, it actually results in a negative feedback, and then it actually stimulates the ovarian production of estrogen instead. So only in postmenopausal women. However, we can give aromatase inhibitors in premenopausal or perimenopausal women by combining it with ovarian suppression. So when we give them ovarian suppression, we make them postmenopausal, then therefore they can actually receive aromatase inhibitors. The side effects are pretty similar. Both of them have menopausal symptoms. Just briefly on this topic, this is very common. We need to help patients manage this. There are drugs that we can use, such as low-dose antidepressants, such as venlafaxine, or another drug called oxybutynin. These drugs have modest efficacy in managing menopausal symptoms. As we know, some patients struggle very much with menopausal symptoms. And this is what I would start with in terms of trying to help them with these symptoms. There are some specific side effects to tamoxifen. The two that I normally point out, which are serious but rare, are uterine cancer and venous thromboembolism. The incidence of this is less than 1% following 5 years of treatment, and that goes up to about twofold when you increase the duration of therapy to 10 years. The two specific side effects to aromatase inhibitors are osteoporosis. So therefore, we need to talk about bone health. I put all patients on aromatase inhibitors on Ostelin as well, and I monitor their bone mineral density. And if obviously they move towards osteoporosis, then I co-manage them with an endocrinologist with bisphosphonates. And I'll talk about that briefly later on. The other side effect that's relatively common in patients on aromatase inhibitors are joint stiffness. So typically they feel the stiffness in the small joints of the hands and feet, and typically it's worse in the morning and gets better as the day moves on. Mood changes are common as well in both of them. In a minority of patients, I need to co-manage them with a psychologist or psychiatrist as well, as some women are very sensitive to hormonal changes in their body. Now, just a brief slide on prevention. This is a relatively recent study published last year, it essentially compared or looked at 5 milligrams of tamoxifen, which is about 25% of the dose of tamoxifen that we use for adjuvant therapy. And what they found is that giving 5 milligrams of tamoxifen in patients with conditions such as DCIS or pre-invasive breast cancer. So all the patients on this study did not have breast cancer. They just had pre-invasive disease, which portends a high risk of invasive disease. So for these women, compared to women on placebo, they were able to halve the risk of subsequent development of invasive breast cancer at a quarter of the dose. And when you look at the side effects such as DVTs that we talked about, et cetera, the incidence was very, very low and comparable to the placebo arm. So 5 milligrams of tamoxifen is very well tolerated. And following this study, I'm actually using it fairly commonly in women with pre-invasive breast disease. The problem here is that they don't make 5 milligrams of tamoxifen and it's hard to find even 10 milligrams of tamoxifen. Most tamoxifen come in 20 milligrams. So it's about finding the right dose. If you can find a 10 milligram dose of tamoxifen, I just ask them to halve it and take it every day at 5 milligrams. Now, briefly about preoperative or perioperative endocrine therapy. So this is a large trial. It's in the UK where they gave 4,500 women endocrine therapy for 2 weeks prior to surgery. So it's what we call a window of opportunity treatment. So typically, women gets diagnosed with breast cancer. The breast surgeon then gives them a date for surgery. So in that time, typically about 2 weeks, they get an endocrine therapy. And why is this useful? Well, what they've done is here is compared the baseline. So this is the baseline Ki-67, a marker of cell proliferation. And they compared it at baseline to the one following 2 weeks of treatment, so the one from surgery. So in these women, if they started off with a low Ki-67, defined as a Ki-67 of less than 10%, and 2 weeks after the endocrine therapy, they also got a low Ki-67. This is a 5 years prognosis. You can see that the time to recurrence was pretty good for that group of women, as well as the group of women who had a high Ki-67 to begin with, and then responded to the treatment just following 2 weeks of treatment. The Ki-67 reduced to less than 10%. So these two groups of women did really well. The group of women that we're concerned about are those that we give 2 weeks of endocrine therapy to before surgery, and even then at surgery, their Ki-67 remains high, suggesting to us that therefore the type of tumor they have is not sensitive to endocrine therapy. So this is useful prognostic information at this point. We haven't actually got treatments that are different for these women at this point in time, but this is an area of active research. And this is just one example of a trial that we're doing in this window setting at St. Vincent's Hospital and actually throughout Australia, but St. Vincent's is the lead site, where we're actually trialing a drug called progesterone in combination with endocrine therapy. And this is based off a seminal publication in Nature by some Australian authors. So we randomized patients to 3 different endocrine therapies, 2 with progesterone prior to surgery. And then we also look at the Ki-67 and see how the addition of progesterone modulates the Ki-67. So this is a trial that's funded by the Cancer Council of New South Wales and currently recruiting. All right, so I'll then shift gears to talk about adjuvant tamoxifen. So this is tamoxifen used to treat patients with breast cancer. So what you can see here is that with 5 years of treatment, patients benefit with tamoxifen. As you can see, the recurrence rate is lowered from the control arm by about 12% in this instance. And that difference actually increases over time. So this is what we call a carryover effect. So 5 years of tamoxifen gives you ongoing benefits in terms of prevention of breast cancer recurrence beyond 5 years. And you can see that too in terms of breast cancer mortality. So 5 years used to be the standard. However, there's been a few trials recently that have explored extending it to 10 years. So we call this extended adjuvant therapy. So this particular trial called the Atlas trial compared 5 versus 10 years. And what you can see is that the 10 years, which is the light blue arm compared to the red arm, does decrease the incidence of breast cancer recurrence as well as breast cancer mortality by small absolute figures, but there is a benefit. So 10 years is now increasingly being used, but I would say not on all patients because whilst the side effects double, for example, DVTs and uterine cancer, the benefits do not double. The benefits increases marginally. So we'd select the patients with a high-risk disease like larger tumors or nodal involvement to go to 10 years. For patients with small tumors that are node negative, we tend to still stick to 5 years. And as mentioned before, there is an increased incidence of endometrial cancer with 10 years versus 5, as well as DVTs and pulmonary embolus, as you can see, a doubling roughly with 10 years. So I think we need to select our patients for extended therapy carefully. What about aromatase inhibitors? So this particular trial is with letrozole. So all patients received 5 years of previous aromatase inhibitors, and then they were randomized to receive another extra 5 years or stop at 5 years, so they went on to get placebo. And as you can see in this trial, the extension to 10 years versus the standard 5 does decrease the risk of disease-free, or does decrease the risk of recurrence with 10 years, and also does improve the survival by just about 0.5%, so not significant. It does, however, also decrease the risk of getting a second breast cancer with the extended therapy. Now, in terms of side effects, the osteoporosis-related fractures did not increase with 10 versus 5, and neither did the risk of arterial thrombotic events. And what this suggests is that we've actually pre-selected the women who have been able to tolerate 5 years of aromatase inhibitors, and perhaps their rate of bone loss have stabilized. So even continuing another 5 perhaps did not actually have a significant effect on osteoporosis. It could also mean that we're actually treating the patients for osteoporosis prevention increasingly, so that this is less of a problem. Now, finally, ovarian suppression, which we talked about earlier, can also be given to women who are premenopausal. And the question is, does that add anything to our current standard endocrine therapies, tamoxifen, as well as the aromatase inhibitors? So what you can see here is that they've divided the patients into 2 groups: patients who also receive chemotherapy, who did not receive chemotherapy, and patients who receive chemotherapy. And whilst the curves are overlapping in the 3 arms, in patients who did not receive chemotherapy, suggesting that tamoxifen is as good as any of the others and ovarian suppression is not required. In patients who did receive prior chemotherapy, the best arm was the patients who received ovarian suppression and exemestane, or ovarian suppression and tamoxifen, which is the top 2 lines. So this highlights that it's really the high-risk patients who we would also give chemotherapy, who may also benefit from ovarian suppression. So we don't use this routinely on all premenopausal women, but certainly the high-risk patients, we would offer them ovarian suppression as well. And the high risk is defined by the patients we tend to treat with chemotherapy as well. We also consider in some patients giving adjuvant bisphosphonates, which are used to treat osteoporosis. And what this meta-analysis of a large number of patients show is that when you give bisphosphonates, there's really no difference in outcomes in premenopausal women, but what you actually see in terms of recurrence as well as breast cancer mortality is that there is a slight benefit in the postmenopausal group when a bisphosphonate is given. The exact mechanism of this is unclear. It's thought that in ER-positive breast cancer, the cancer cells tend to like to metastasize to the bones, and if we give a bisphosphonate, we actually alter the soil in which the cancer seeds into, which is the bone. So this is perhaps one of the ways in which bisphosphonates can alter the outcomes in postmenopausal women in an adjuvant setting. So we would consider adjuvant bisphosphonates really in postmenopausal women with higher risk breast cancer. And giving bisphosphonates is also not a bad idea, because we talked about osteoporosis being a side effect of aromatase inhibitors. So you might get an extra bang for your buck as well in terms of prevention of osteoporosis in this group of women. And this is just really demonstrating what the recommendations are in terms of doing a baseline bone mineral density, and then recommending exercise, calcium, and vitamin D routinely as well. We can give zoledronic acid. The only thing is that it's an infusion. It's given every 6 monthly. But increasingly, we're also giving Prolia, denosumab, because that's a subcutaneous injection. And once again, we can co-manage this with the GPs, because the patients can actually receive this drug in the community. One important side effect that's common to both is the risk of osteonecrosis of the jaw. So they do need to see the dentist to get a clearance beforehand. And it's also important to note that this is not PBS reimbursed for early stage breast cancer, and those are roughly about the prices, about $300 a dose. Now, we talked about chemotherapy for some patients with ER-positive breast cancer earlier on. So the standard therapy for patients with ER-positive breast cancer is endocrine therapy, but some patients also get, in addition to that, chemotherapy. And in the past, we used to make these decisions based on the size of the tumor or the number of lymph nodes involved. So the higher risk patients tend to get chemo, or the younger patients. But it's not a very satisfactory algorithm because it doesn't actually take into account what we call the personality of the tumor. So you've got the size of the tumor, but you've also got the personality of the tumor. And I think a chemotherapy decision should be made more on the personality of the tumor rather than the size of the tumor. So this test looks at 21 different genes. It's actually not done in Australia, it's sent to San Francisco, and it quantifies the likelihood of recurrence in women with ER-positive breast cancer. It also predicts the magnitude of chemotherapy benefit, which is the primary reason why I use this, not really from a prognostic perspective, but to help guide whether we should add chemotherapy to the patient or not. It is not PBS reimbursed, and it costs currently about $5,000, although that does change with the Australian US dollar exchange rates. And there are newer tests such as EndoPredict, which is less validated, which is also cheaper. So what we do when we get the test done is that we get a recurrence score. And the recurrence score then guides us to whether chemotherapy should be recommended or not. So in women over 50 years old, if they get a recurrence score of 26, there's a high risk of recurrence, and the benefits of chemotherapy are likely to be greater than the risk of side effects. But for women under 50, that recurrence score for recommending chemotherapy drops to about 21. Okay, I'm changing gears now and moving from early stage breast cancer to advanced breast cancer or metastatic breast cancer. And typically this happens in a setting where patients may have had prior treatment for the early stage breast cancer and the cancers come back, suggesting that the cancers learn to develop mechanisms of endocrine resistance or resistance to those endocrine therapies we talked about. And there's a variety of mechanisms for endocrine resistance stated here. And increasingly, there are a number of clinical trials that are using these drugs to overcome these specific mechanisms of resistance. So this is an active space, metastatic breast cancer, where there's lots of clinical trials. And one of the clear targets that we have in metastatic ER-positive breast cancer that's become resistant to traditional treatments such as aromatase inhibitors and tamoxifen is the estrogen receptor, not surprisingly. And it's found that in patients with metastases, the incidence of ESR1 mutations, ESR1 is the gene that codes the estrogen receptor, is actually significantly higher. So in this instance, 20%, in some instances up to 40% of metastatic breast cancers harbor this ESR1 mutations. And the ESR1 mutations make the estrogen receptor constitutively active. So it doesn't really need estrogen to bind to it to be active. And it's on all the time. And traditional therapies such as tamoxifen and aromatase inhibitors is not particularly effective in this setting. And we know that patients also with ESR1 mutations actually do worse than patients with the wild type ESR1. So this is the survival probability. Wild type is in black, and the mutant tumors are, patients with the mutant tumors are in orange, and you can see that the survival probability is less if they have a mutation. So there are a number of escape pathways, as mentioned earlier, and an area of active development for these escape pathways are the CDK or cell cycle pathway, as well as the PI3 kinase mTOR pathway. So I'll talk about two of these strategies that is currently has drugs in use to target these escape pathways in endocrine resistance. So this is the first one that was approved back in 2014. It's a drug called everolimus, which is an mTOR inhibitor. And what you can see here in these trials, one is in combination with exemestane and aromatase inhibitor, and the other one is in combination with tamoxifen. So they both have an endocrine therapy backbone where everolimus is added to that drug. And when compared to placebo, there's about a doubling of the median progression-free survival. So you can see clearly that the patients who received the exemestane did better on both trials here. And there's also an overall survival in both trials where there's a good separation of the curve. So these trials led to the PBAC approving everolimus for the treatment of metastatic breast cancer in patients who previously progressed on an endocrine therapy. This was a good drug. However, its use has been limited by its side effects. It causes lots of mouth ulcers, fatigue. It was actually quite difficult to manage. So while it was approved and its use was quite popular, perhaps a couple of years ago, there are now better drugs that are on the market, and its use has actually dropped over time. Perhaps the flavor of the month are what we call CDK4/6 inhibitors. And CDKs are involved in cell cycle, but also in multiple other cellular processes such as RNA transcription. The three that I'd like to focus our attention on today are the three CDK4 and 6 inhibitors. These are palbociclib, ribociclib, and abemaciclib. They're all PBAC approved for use in metastatic breast cancer. And importantly, they are also an oral drug, which means that we often have to co-manage these patients together with the general practitioner as it's being used in the community. And this is just a comparison over time showing that in the past, when patients had recurrence of the breast cancer, the standard of treatment used to be an aromatase inhibitor alone. And on average, if you look at the orange bars, they get about a 14-month benefit progression-free survival before they progress, before the cancer stops responding to the treatment. Now with the addition of a CDK4/6 inhibitor, really the results from all three are very similar. So a CDK4/6 inhibitor plus an endocrine therapy backbone, we can actually increase that by about 10 months. So they get about 2 years benefit from these drugs and these are just 2 oral tablets they take in the community. So these are the curves from the seminal trials of palbociclib, ribociclib, and then abemaciclib. And if you look at the hazard ratios, it's all very similar. It's all about 0.55 to 0.65. So suggesting that this is probably a class effect. And they're actually now replacing chemotherapy as the preferred first-line treatment for women with ER-positive breast cancer who develop recurrent or metastatic disease. 2 tablets replacing chemotherapy, which is great from a patient perspective. What are some of the side effects of these CDK4/6 inhibitors? Perhaps the most important one to look out for is neutropenia. So we actually monitor the neutropenia, and if it's below 1, we then dose reduce. But it's a different sort of neutropenia that you get with CDK4/6 inhibitors than you do with chemotherapy. Patients seem to tolerate it very well. They tend not to need hospital admissions, even if they're neutropenic. But in spite of that, we do manage their neutropenia with dose reductions, and it's actually fairly easy to use. So I'd just like to summarize as I come to an end for this talk, that what we've talked about today are some of the treatments for early stage breast cancer, and I tend to divide them up into 2 groups. They're pre and perimenopausal women, where I would consider giving tamoxifen, or in the high-risk women, ovarian suppression plus an aromatase inhibitor. Increasingly, for some patients, we're giving extended endocrine therapy. And for women who we're not sure about whether we should give chemotherapy or not, I tend to recommend genomic testing as well. For postmenopausal women, the key differences are that the gold standard is an aromatase inhibitor. We can start with that. And I would also consider using bisphosphonates for these women based on the meta-analysis data, as well as their increased risk of osteoporosis. For metastatic breast cancer, the first-line therapy, which is PBS approved, is the aromatase inhibitor with CDK4/6 inhibitor, 2 oral tablets. In the second-line therapy, we might consider the everolimus, which is the earlier drug that I spoke about, or fulvestrant. I didn't spend a lot of time talking about fulvestrant because it's actually not on the PBS. However, it's available on a cost-share program with AstraZeneca, where the patient pays about $4,500 to $5,000. And if they get ongoing benefit, which is 3 months worth of drug, and if they get ongoing benefit, they will get the drug free of charge from AstraZeneca. And then the nth line. But really, I'll talk more about the nth line in a minute. But actually, while I've got this out, I tend not to use tamoxifen in the nth line. I tend to put a lot of patients into clinical trials. There's a lot of research and clinical trials being evaluated in Australia. Our clinical trials activity is increasing, and this gives patients an opportunity to access a whole new array of different drugs they can't actually get on the PBS. So I tend to put my patients following first-line therapy onto clinical trials. And there's also clinical trials in the adjuvant setting or for early-stage breast cancer, but less so. But certainly as CDK4/6 inhibitors have been shown to be of benefit in a metastatic setting, where they're now being evaluated in the adjuvant setting as well. So this is just a summary of some of the breast cancer trials we have at St. Vincent's. As mentioned before, it's an active space. I've split it up according to the subtype, hormone receptor positive, where a lot of clinical trials are with the selective estrogen receptor degraders, the oral ones that we've mentioned earlier, as well as some other drugs that target alternative pathways, such as alpelisib, which is targeting the PI3 kinase pathway. The HER2 positive space, we've also got quite a number of trials here. And in triple negative, we've got a number of trials, including immunotherapy trials and vaccine trials, etc. So we do have a large number of trials at St. Vincent's that we offer patients the opportunity to participate in. And we've also got a molecular oncology study whereby we take the patient's tumor and do whole genome sequencing on the tumor to try to identify some potential targets that's not traditionally looked for in standard pathology tests. Another thing that we tend to do at St. Vincent's, or we offer all patients, is the opportunity to participate in Project SHARE, which stands for Specimens Help All Research Efforts. So we collect tissue from participating and consenting patients, from non-malignant tissue to carcinoma in situ to breast cancer to even metastases, where we perform metastatic biopsies on patients. This tissue then gets sent to the labs at the Garden, including my lab, this really enables patients and empowers patients to be critical partners in our research endeavor to find better treatments for them. So just a summary of management considerations in ER-positive breast cancer. We spoke about low-dose tamoxifen for prevention. We've talked about the increasing use of extended adjuvant endocrine therapy, management of side effects, consideration of adjuvant bisphosphonates in postmenopausal women, the use of multi-gene assays to guide chemotherapy decisions, combination endocrine therapy and oral targeted therapies replacing chemotherapy in the early line treatment of advanced breast cancer, and then finally, importance of clinical trials and research for cancer patients. Thank you. This is my contact details. If you need to reach out, please do send me an email or call my practices. And thank you very much for your attention.